My topic is very interesting. Erectile dysfunction in diabetes, demystifying the untold mystery. You'll agree to me that many times when we interview a diabetes patient, we don't ask about the sexual difficulties. Leave aside the female patients, even male patients, we don't interrogate about their erectile dysfunction or any issues related to sex life of the patient. But it's part of the story. Erectile dysfunction doesn't not only tells about the sexual dysfunction, but it also tells about the endothelial dysfunction of the body. So we should make few habits while interviewing diabetes patients, and one is to ask a good history related to sex life and the issues related to sexual dysfunction. Like we forget to examine the foot, like we forget to examine the fundus, we also forget to take a history related to the sexual dysfunction. So in next 18 minutes, I'll be demystifying the untold mystery of the erectile dysfunction. You know, diabetes is a chronic and widespread disease, and we have almost 77 millions of patients, which is increasing every minute, every hour, and every day. The global prevalence, the national prevalence is going in geometric progression. And there are many short-term and long-term complications, as well as micro and macrovascular complications. Sexual disorders represent one of the neglected long-term complications which can affect both male and the female sex. The most important magnitude is a common underestimated complication like erectile dysfunction affects more than 50% people of diabetes. You'll be surprised to know if we calculate this risk, more than half of the people have this dysfunction, and dramatically it raises the risk developing erectile dysfunction by 2.5 fold. Once the patient becomes diabetic, the risk is increased 2.5 fold in comparison to the non-diabetic counterpart. The erectile dysfunction represents an early sentinel of cardiovascular event. I have already told it's endothelial dysfunction preceding a coronary event by at least 3 years, and thus warrants remarkable consideration by clinicians so as to prevent one of the main cause of death among subjects of type 2 diabetes. You can predict anybody who is having a ED is going to have a coronary event after 3 years. So if you analyze these two issues, diabetes is an established risk factor for sexual dysfunction in male, and threefold increased risk of erectile dysfunction was documented in diabetic compared with the non-diabetic male. Already I have told that, but it's still not clear whether hyperglycemia, which is the main determinant of vascular complications, is responsible for ED, or we have other pathogenetic mechanism of sexual dysfunction in diabetes. Otherwise, the diabetic people may present with several clinical conditions, including hypertension, cigarette smoking, obesity, metabolic syndrome, or dyslipidemia, which themselves are risk factors for sexual dysfunction in both the sexes as well. So they have common risk factors, and hyperglycemia itself can precipitate, and atherosclerosis is the common to both the conditions. Reviewing your knowledge of penile erectile structure, the erectile dysfunction is defined as a persistent failure to achieve or to maintain a penile erection satisfactory for sexual intercourse. And penile erectile structure are corpora cavernosa, which receive the blood supply by the internal pudendal artery that continues as the penile artery, which all of us know. The corpora cavernosa are made of sinusoids capable of notable volume expansion, and furthermore, they are enclosed in box fascia, which rigidly limits their expansion beyond a specific point, and this allows the penis to reach its maximal rigidity. This is the in nutshell, the mechanism of erection and penile structure. The sequential series of events which happens during erection are in the flaccid state. The cavernous smooth muscle shows tonic contraction, allowing only minimal arterial flow for nutritional purpose. But in sexual stimulation, the neurotransmitters are released by the cavernous nerve terminals with an ensuing relaxation of cavernous smooth muscles, which leads to the dilatation of the arterioles with a subsequent arterial blood flow increase. And sinusoids in turn expand, and the subtunical venular plexus is compressed between the sinusoids and tunica albuginea, decreasing the venous outflow. So the erection depends upon the parasympathetic nervous system, which causes smooth muscle relaxation by nitric oxide mediated action. This is a nutshell and summarizing the physiology, the sexual stimulation leading to peripheral or the central reflex, the parasympathetic and NANC neurotransmitters, relaxation of the vascular and cavernosal smooth muscles leading to increase in the blood flow, increase in the intra cavernosal pressure leading to penile erections. The erection needs integration of vascular and nervous system, which already we have seen. So this physiology needs the inputs from parasympathetic nervous system and local engagement and the vascular mechanisms they also play. The nitric oxide mediated erection is dependent on the testosterone, and therefore the etiology of erectile dysfunction includes the psychogenic due to stress, depression, anxiety, or the organic forms. The former in turn comprises the endocrine causes such as hypogonadism, the hyperprolactinemia, the hypothyroidism, Cushing's disease, Addison's disease, and non-endocrine causes such as vasculogenic, neurogenic, and or iatrogenic forms. The integration of the vascular and nervous system results the vasculogenic etiology, including the atherosclerosis, ischemic heart disease, the peripheral vascular disease, and the venous outflow such as venous incontinence, the Peyronie disease, and the altered anatomic integrity of the tunica albuginea are responsible. The neurogenic etiology encompasses the lesions of the upper motor neuron, the sacral lesions, the pudendal nerve injury, and the iatrogenic etiology is extended to pelvic surgery and drugs like beta blockers, the anti-androgens, the luteinizing hormone releasing agonists, and antagonists. So this is a pictorial presentation of erectile dysfunction, where you can see the corpus cavesum and the corpus cavernosum in a flaccid state and the erect state, and the psychological factors, the hormonal factors, the blood vessel factors, and the nervous system factors are the causes causing the erectile failure. So, in nutshell, summarizing, the in type 2 diabetes, the raised blood sugar, the insulin resistance, which is associated with comorbidities like hyperlipidemia, hypertension, obesity, and the sedentary lifestyle, results in vasculopathy, neuropathy, hypogonadism, and the local factors, and ultimately leading to decrease in nitric oxide production and the vascular and cavernosal smooth muscle relaxation. Depression, anxiety, and decreased libido also contributes, leading to the erectile dysfunction. The pathophysiology in the man mainly based on hormonal changes, endothelial dysfunction, neuropathy, and cavernosal structural or the functional changes, which we have already seen. And the type 1 and type 2 diabetes exhibit these changes, though they are more pronounced in type 1 diabetes. The neuropathy is a contributor to the pathophysiology, is significant contributor in terms of nerve conduction and the sphincter, NI, electromyography, heart rate variability, and the quantitative sensory testing evaluation. It has shown abnormalities in men with diabetic erectile dysfunction, and the autonomic dysfunction is there associated with diabetic neuropathy. It's linked to the selective neurodegeneration, which in turn decreases neuronal nitric oxide synthase, and activity and diminishing nitric oxide associated with the impaired the nitrogenic relaxation in the corpus cavernosum. So the neuro degeneration seems to be a nitric oxide dependent process based on the evidence on the oxidative damage through the formation of the oxygen free radicals. So endothelial dysfunction contributes to the erectile dysfunction that we have already seen, and that is partly based on the levels of the nitric oxide. The hyperglycemia in people of diabetes results in accumulation of advanced glycation end products, and the advanced glycation end product results in vascular thickening, the decreased elasticity, and the atherosclerosis. The increased levels of the endothelin and the upregulation of the endothelin receptors in the corpora cavernosa contribute to the penile vasoconstriction. So here, the impaired bioavailability of nitric oxide and the oxidative stress, the like free radical damage, interferes with the nitric oxide, and they're not available for the purpose for which they are meant. So we need to treat these patients because the potential to decrease the cardiovascular morbidity and the mortality based on the functional obstruction and then lipid-rich minor lesions, which may be dangerous in the later stage. So the improvement in the erectile function occurs by aggressive lipid lowering and improves this has to be targeted in these patients. The structural changes like smooth muscle content in the reduced while the collagen deposition is increased, and the thickening of the basal lamina and loss of endothelial cells have been also reported. So the advanced glycation and product play a fundamental role, decreasing the complication, the compliance of the corpora cavernosa, and impairing the smooth muscle relaxation by degenerating the free radicals, and the cavernosal smooth muscle relaxation may also occur due to decrease in cyclic GMP dependent protein kinase 1, the PKG1, that diminish the activity of cyclic GMP intracellular pathway. The hormonal changes have already told the low testosterone levels, including total free and bioavailable testosterone, the common findings in the man, and the hypogonadism in the diabetic men is commonly associated with age, obesity, metabolic syndrome, and insulin resistance. The early detection of the metabolic disease and the patients with erectile dysfunction may be a gateway to the reduction in the endothelial dysfunction in the younger male and the increased cardiovascular risk who present at the treatment of the ED alone. So with this much of background, let us quickly see the diagnosis and the management. It's based on the sexual and medical history I have already told. We are forgetting to classify this, ask the patient regarding the presence and the clinical signs of the cardiovascular disease, and the neuropathy can be identified, and penile examination can identify other comorbidities such as Peyronie's disease. So you can examine the genitalia of these patients also, and the hormonal assessment based on testosterone and prolactin is important due to their high prevalence in the diabetic men and their implication for the treatment. Testosterone should be measured by early morning, and for hypogonadism, we need to work out the patient and treat. So this is minimal diagnostic evaluation, basic workup in the ED. You took a detailed psychosexual history and identify, other than the ED sexual problems, identify common causes of ED, identify reversible risk factors, as well as the assess psychosocial status. The focused physical examination should examine the penile deformities, the prostatic diseases, the signs of hypogonadism, the cardiovascular and neurological status, finally the laboratory tests. The glucose lipid profile and the total testosterone, if indicated, the bioavailable free testosterone are to be assessed. So the Princeton consensus panel includes the sexual inquiry, the clinical cardiovascular evaluation, the indeterminate risk, and the cardiovascular assessment and the risk stratification. It can be low risk or high risk depending on the sexual activity, the deferred until the stabilization of the cardiac condition, or initiate resume sexual activity and therapy of sexual dysfunction. So this Princeton consensus panel, you have to classify it as a low risk, intermediate risk, and the high risk. And the ideal treatment approach, we have to establish the cause of erectile dysfunction, which is most of the time associated with stress, non-controlled diabetes. The targeted treatment must select patients in early stages, and the changes in the first phase are reversible with the insulin replacement. For the neurodegeneration, second phase is irreversible. Once the nerve is affected, it's irreversible. Despite these unfavorable data, the clinicians need translational input from the scientific team to treat these patients. So the ideal treatment approach is to diagnose the cause, and you have to take a detailed history, evaluate the patient biochemically, and examine the patient physically, and the pathophysiologic changes described above and corroborate with the erectile dysfunction's cause. So typical treatment plan has 3 visits, 1, 2, 3. In visit 1, the patient story and examination, additional testing and cardiovascular risk assessment, medication. Visit 2, we see the efficacy of the disease, the treatment, and the more advanced therapy, and the referral for the further evaluation to endocrinologist or the sexologist. And visit 3, we ask, did it work, and still referral. Lifestyle changes and concomitant medications for other comorbidities are important. To control not only the blood glucose, the blood pressure, cholesterol, the thyroid, the weight, all are important. And the A1C around 6.57 is very important to achieve a good sexual function. More is the obesity, more is the BMI, more is the blood glucose, more is the comorbidity, lesser will be the sexual function, and erectile dysfunction will be very prevalent. So this regular exercise, diet, and lifestyle factors are to be reinforced, and anti-hypoglycemic agents on A1C, body weight, and erectile functions. You can see the drugs like insulin, sulfonylurea, metformin, and all oral drugs. A1C is decreased by all. Body weight, few increase like insulin, like sulfonylurea, like glitazones, they increase the body weight. But when it comes to the sexual dysfunction or effect on the erectile function, they demonstrate the potential, and the drugs all help improving the erectile function. So drugs are not a culprit in causing this, especially oral anti-diabetic drugs. So the drugs available with us are sildenafil, vardenafil, the avanafil, and the tadalafil. You know about the dose, and to given 30 minutes to 1 hour before, and you know the side effects and its different monitoring. So the mechanism of action of the phosphodiesterase type 5 inhibitors. These phosphodiesterase inhibitors are type 5, and we see the sexual arousal stimuli, parasympathetic nerve cells, nitric oxide, and then the GTP converting to the CGMP and the inactive metabolites. So in PD5, we work alternative, and we have to, if it doesn't work, we have to think of the vacuum pump, the alprostadil, the combination of intracavernous injections, and also penile implants. So here the other drugs which are available with us, the alprostadil, the avipapdil, the phentolamine, and the vacuum pump device, and the penile implants. Here it shows some vacuum erection devices for the purpose, and intraurethral alprostadil for sildenafil failure patients. Intracavernosal injection can also be practiced, and penile implant is also advocated. So the diagnostic and the therapeutic algorithm of the erectile dysfunction is shown here. The most important NOAHA 3-4 sexual activity has to be assessed. The cardiovascular risk and multi focal neuropathy is to be assessed, and the different risk factors are to be seen depending on the level of the sexual dysfunction. So finally, ladies and gentlemen, I'll request you to evaluate this important part of each and every patient, to take a history of their sexual dysfunction, to diagnose by clinical examination and biochemical evaluation, and treat it, whatever may be the risk factor, the blood glucose, the weight, the blood pressure, the cholesterol, to treat it ask the patient to lose weight and give drugs which will help and increase the confidence of the patient. So every man with diabetes has this erectile dysfunction, and it has to be treated, it has to be evaluated, because in due course of time it affects the cardiovascular system, and patient have uh, uh, coronary artery disease if not treated adequately. So you have to plan a goal-directed therapy, identify the patients at risk for the primary treatment failure, and refer to the specialist early if we fail. I thank all of you for the time, and I also thank Dr. Shubham Das and the whole team of this CME for having been invited me. And I'm sure this will add to your knowledge and change your approach when you're planning the treatment of your diabetic patients. Thank you. Thank you, everyone.
Yes, thank you, Dr. Panda, for the nice and the lucid deliberation. And now there are the few questions in the chat box. That the first question is, how do you approach a case of erectile dysfunction who is having good glycemic control?
Due to a certain emergency meeting, Dr. Panda had to leave now. He will be rejoining shortly, and he will be addressing all the questions then. We have quite a few questions from this session right now, so we'll be addressing those at that time. So thank you, Dr. Panda sir, for a lucid and elaborate talk. We now move on to the next session, and we'll be taking the questions for this session shortly as soon as sir joins. Thank you.